Welcome to Kidney Talk, a program of Renal Support Network, a show that streams health, happiness, and hope to the kidney community. You can download all Kidney Talk shows from iTunes and find a variety of resources to help you navigate this illness at rsnhope.org. Please welcome your host, Lori Hartwell, who has lived with kidney disease since the age of 2.
Well, welcome to Kidney Talk. Today we're going to be discussing a very serious issue. And the reason I say it's very serious is it's because it's a condition that can happen when you're on dialysis, and it's called calciphylaxis. And sadly, I've had several friends that have suffered from this illness. And when I say suffer, they suffered. It's very painful. And I'm very excited today because we're going to be talking about new hope of therapies for calciphylaxis. There's some new medications and trials coming out. And today we're going to be talking to Dr. Sinha and Dr. Nigwekar. So tell us a little bit about why people who have kidney disease are more prone to bone and mineral disease.
Patients with kidney disease are prone to quite a lot of things, unfortunately, but mineral and bone disorder is one of the key things that become problematic as the kidney function starts to drop. And that's because of the role the kidney do. You know, cardiologists will tell you that the heart is the most important organ in the body, but it is absolutely the kidneys, because they regulate all the salts and minerals in the body, as well as blood pressure, so many things. And as kidney function declines, particularly those who are on dialysis, they retain certain salts, particularly things like phosphate. And the kidneys also regulate our vitamins, so things like vitamin D that are so important for bone health. The kidneys are responsible for making that work, so activating vitamin D. And if a kidney can't produce, you don't activate vitamin D, so you don't get the beneficial effects. So again, you get problems with your bones, you get problems with calcium and phosphate, getting stuck in blood vessels, also affecting your fracture risk. So lots of ways that patients with kidney disease, particularly those on dialysis, are more prone to these problems. A mixture of retention as well as problems with hormones and regulating those.
You know, the kidneys are the master chemist. I mean, you know, the heart gets a lot of attention because obviously we need that, and our lungs, but the kidneys are just as important. And, you know, people often don't give them as much credit. So, you know, when you have kidney disease, it's very common that you take phosphate binders. So can you tell us a little bit about how phosphate binders help prevent, you know, advanced bone and mineral disorder? Like, what is the mechanism?
Thank you for having me. As Dr. Sinha was alluding to in her previous comments, kidneys are integral part of managing mineral and bone parameters. One of the most commonly discussed analyte is phosphate. And I'm sure individuals who have kidney disease, and particularly those who are on dialysis, may have heard about phosphate. Every few weeks, a dietitian in particular may show up at your dialysis chair with a chart that mentions the level of phosphate and likely has some smiley and frowny faces. The main reason they're doing that is because phosphate, in a number of studies, has been shown to predict heart problems, events such as stroke, and also rare conditions such as calciphylaxis that we will discuss today. There are two ways, broadly speaking, to manage phosphate. One is diet, and the second is medications such as phosphate binders. What the binders do is essentially they bind the phosphate that is coming from the dietary intake. So every time we consume food, and certain foods, of course, are going to be higher in terms of their content of phosphate than the others, but all that phosphate is going to be absorbed, or most of it is going to be absorbed in the gut. And a large part of it will go into the blood circulation, and some of it will cause problems in terms of the bone health, in terms of the heart health, in terms of the blood vessel health. So the binders try to block that absorption of phosphate. Now, are they perfect? Unfortunately, they are not. They cause sometimes side effects. Sometimes they may not be efficient, so the individuals are then stuck with taking many pills or capsules every day. But that is one of the best approaches that we have at present in terms of controlling the phosphate in individuals with advanced kidney disease, particularly those who are on dialysis.
Well, I took phosphate binders for probably, 16 years, 17 years. In the early stages of phosphate binders. And, it's really important that the people listening that when you take phosphate binders, make sure you take them with your meal, not an hour after your meal or an hour before your meal. You need to take it, around the time you eat because it binds to the food and then you void it out. So it's very important. I wanted to just mention a little bit because I think it's worth saying because there's so much phosphorus out there. We're somewhat climbing an uphill battle. Processed foods are just loaded with them. Anything you want to say about that? Because I think people really need to know when you eat processed foods, it's a preservative, phosphorus is. So you don't even know you're eating it.
That's an incredibly important point you raise. So there is a kind of a well-recognized entity now of quote-unquote hidden phosphate. And that, part of that hidden phosphate is coming from foods where, the labels do not clearly identify phosphate as one of the major ingredients in there. And that is particularly true when it comes to processed foods and most of the fast foods. In addition to the high phosphate content of many of those foods, particularly colas, for example, as an example of these foods and beverages, the absorption of the phosphate from those foods is also way higher, meaning for the same amount of phosphate that comes from, let's say, vegetable protein, you contrast that against the phosphate that is coming from a processed food. Even though both food items may contain the same amount of phosphate, the human body will absorb way more phosphate that is coming from the processed food as compared to the vegetable protein. So in addition to the content of the phosphate, there is also a difference in terms of how the human gut absorbs and interacts with that phosphate. And that is the reason that there is a lot of emphasis now in terms of educating individuals who have kidney disease, in terms of paying close attention to those labels and really understand the high hidden phosphate content in many of these food items, particularly the processed foods and the fast foods.
Yeah, I just want to come in on the fizzy drink side of things. I was amazed at the effects that cutting out fizzy drinks can have on a patient's phosphate because you just see it as a liquid, and even small amounts can have an effect on phosphate. So that was a revelation to me when my dietitian shared that with me, and the impact it can have on our patients. So absolutely echo the hidden phosphorus out
I know.
there.
I mean, soda. I mean, even tea. Now, if you get bottled tea, it has phosphorus in it. So it's better to make your own tea at home because it's a preservative and it's not that hard. And it's actually better. What are some of the early warning signs if your phosphorus is high or I can't mention phosphorus without calcium. And then there's also the term that patients hear is, secondary hyperparathyroidism. They all relate to bone and mineral health. So what symptoms do you start to get if you have a high phosphorus? Which I know this question, but it's a pop quiz. I know the answer.
It's really hard, isn't it? I mean, part of the problem is you don't get any symptoms. The vast majority of people don't. So, we're rounding and we're saying, your phosphate's up or your calcium's down or up and, you've got secondary hyperparathyroidism. And you don't often feel it. Some people might get itchy. Some people, might notice that, some redness around the eyes. But the vast majority of people, they don't feel it and they're just told there's a problem. Sadly, if it goes unchecked, that's when problems can develop and people can develop an increased risk, things like fractures and muscle weakness. But largely, it's really asymptomatic until things start to go wrong. And you certainly don't feel the deposition of calcium phosphate or, the formation of things like calciphylaxis until you've got it.
Right.
And then sadly you do feel it. And it's almost, you wish you could go back and change it. Yeah, it's difficult.
I just remembered when my phosphorus was high that I had this like itch that was inside of my body. I mean, it wasn't an outside itch, it was internal. And the only way, I mean, it's horrible, like the only way I could really get any relief, and I get it on my lower belly level, is just to hit my belly, like lightly, like it almost just the pounding helped relieve it. So that tells you that it's like internal, and it's pretty horrific when you're trying to sleep and you itch, and then your skin's dry from dialysis. So yeah, it's not fun at all. Do people who do home dialysis, what is your opinion on that when it comes to bone and mineral health?
Yeah, so in general, adequate dialysis in somebody who has advanced kidney failure is, of course, recommended for a variety of reasons, including managing their bone and mineral complications. I mean, if we just take a step back and really kind of admire the intense work that kidneys do, when it comes to phosphate, on average, in somebody who is following Western diet, the intake of phosphate is approximately 1.2 grams every day, of which almost 800 milligram or so will get absorbed in the intestines, and almost all of that will be eliminated in the urine as long as the kidneys are working fine. And the remaining 400 milligram will not get absorbed and will get excreted in the feces. As you can imagine, when the kidney function is not there, if the intake remains the same of around 1,200 milligrams a day after day, you're getting into this positive phosphate balance of around 800 milligrams per day. So how do we tackle that? Obviously, dialysis can help remove some of that phosphate. The limitation is, of course, dialysis, removal of phosphate is time dependent. The longer you are on the dialysis machine, more will be the phosphate removal. But it's not practical to be on dialysis for a long durations of time for a variety of reasons. But in general, the programs that offer longer sessions of dialysis, patients tend to have lower levels of phosphate compared to the programs that do shorter durations of dialysis. But it does come at a cost: convenience, burden to the patients, burden to their informal caregivers. So there's a balance that needs to be struck. But of course, in many individuals, we can do that with a combination of approaches, including dietary restriction, medications like phosphate binders, education of their caregivers in terms of which foods to prepare and which to avoid, and then, of course, then a dialysis prescription. But it's not uncommon to come across a patient who is on a home program and is getting, 7-8 hours of dialysis in a day. That patient actually frequently runs completely normal phosphate even without being on a phosphate binder. And it sometimes actually runs low phosphate compared to the normal range and has to be supplemented.
We definitely see the need for supplementation in those groups that are on nocturnal HD. And as you said, 7 to 8 hours. But if they tend to be on a sort of Mediterranean diet, so they've almost restricted a bit themselves. But yeah, having to give them phosphate in their dialysate is very different to what we're usually used to. So yeah.
Well, I just recalled a memory because when I got my fourth transplant, a little over 10 years now, got to brag, I had to drink phosphorus, like a phosphorus supplement. And it was so weird because like your phosphorus is way too low. You have to drink this. And I just remember thinking, wow, what a turn of events. Phosphate binders last week, phosphate supplement this week. So it was a little crazy. We're going to switch a little bit to talking about this severe condition people can get when their bone and mineral metabolism are out of whack or some other reasons. It's called calciphylaxis. Can you explain this condition and what it is?
You described it really well earlier, Laurie. It's a really awful condition to have because it's so painful. But the reason why people get it, and it is largely in people who are on dialysis, although you can get it if you're not on dialysis, because of those minerals and bone disorders that we talked about earlier. The calcium and phosphate, the things that are supposed to stay in your bone compartment, end up in the vascular compartment, so in your blood vessels. So they end up clogging up the small blood vessels that supply your skin. So those blood vessels that are supposed to be really nice and elastic and allowing blood to flow through them, they start to become slightly calcified. And over time, that calcification is irritating to the skin around it. So you start to get the skin ahead of that getting deprived of oxygen. And when that happens, it's lost nutrients, it's lost oxygen, so the skin can start to break down. And when that happens, that's when you start to get ulcers forming. And they're really painful to the point where you might look at it and think, well, that doesn't look like very much. But the patient will be telling you, this is really, really sore. So it could start with, a little bit of a sort of lacy-looking rash or a bit of a lump just under the skin that looks really harmless, but you try poking it and, the patient will jump off the bed. And so that they can be some of the earlier signs. And then eventually that sort of lump or rash will start to break down and you'll start to get what looks like a sore that doesn't really heal on its own. At that point, that's usually when people start to ask for help, when the sore isn't healing. Ideally, what we want to do is get people flagging that earlier on, when it's still that lump or that rash. But that's sort of what people might experience when they start to develop calciphylaxis.
Well, and it's always important when you see any kind of open wound on your body to talk to your doctor. But I'm a big believer is whenever I see any type of open scratch or anything, I cover it immediately because there's all kinds of, I imagine you could get a staph infection through that sucker, right?
Mm-hmm. Yeah, totally.
Because at any time, I get so worried. Like, I get a little scratch and I'm like, I look like, I've got a big piece of gauze around it because I had a staph infection once and it's not any fun.
No, you don't want it again, do you?
It's no fun. How many people are at risk for calciphylaxis? Is it prevalent or is it a small group of people? But if it's you, it hurts for sure.
Yeah, no, it is. Luckily, it's a rare entity, which is probably the only good thing about this disease. But obviously, a person who has it, it doesn't really matter that much. But, on average, one can, at least in dialysis patient population, it is typically seen in that patient population. But even there, it is quite uncommon. Less than 1% of dialysis patients will develop this complication of calciphylaxis.
Well, that's 5,000 or 6,000 people in the U.S. If it's 1% or less, that's 5,000 or 6,000. Does it go undiagnosed sometimes?
Well, sure. As you can imagine, for many other rare diseases, the awareness or the methods to kind of diagnose are still pretty much in infancy. So it's not uncommon that the condition may not get diagnosed in the early stage, or in some cases may not get diagnosed at all until the patient succumbs to it. So that is a challenge, and individuals like Dr. Sinha and I and many others, one of the missions we run is to kind of educate the clinical providers about this condition. It's also seen in patients who are not on dialysis, although it's even more uncommon in that context. But it is seen in essentially across the spectrum of kidney disease, including in patients who have completely normal kidney function. But it is most commonly seen in patients who have advanced kidney problems and are on dialysis.
I'll never forget, I had a friend, her name was Marcia. She had 2 children, and she ended up dying of calciphylaxis. It was so severe, and she was in her early 40s. And she was also diabetic. I don't know if that made it a little bit worse, but I just recall her just looking for, like, what can I do? What can I do to get better? And why don't you tell us a little bit about that, what treatments are available? And then we can go into, there's hope because there might be an effective treatment that's coming to the market soon, but they're doing a clinical research trial. So what are the current treatments available to patients for calciphylaxis?
Laurie, that's such a difficult question because there are so many things that we do. Whether they're actually treatments or not, we're struggling with, and that's what makes the condition so hard. when you have someone in front of you who's in so much pain, we want to help. So we will often try anything. So there are a whole range of things that people do, and it varies from country to country. It varies from doctor to doctor. People will try and do things that try and get rid of things like phosphate. If you can get the kidneys working as well as possible, or if you can get the dialysis as efficient as possible. So people have tried all sorts of things like increasing dialysis frequency, increasing the amount of time someone's on dialysis, whacking up the phosphate binders, cutting out calcium, as well as sort of more novel things like things as odd as asking people to go and sit in a hyperbaric oxygen chamber. So many things that people have tried. Surgery to try and reduce the hormones that contribute towards calcification. But despite all of those attempts, I don't think we can safely say that we have treatments out there. What I would say is that really good team working is probably one of the most effective treatments. Having a clinic like Dr. Nigwekar's, it's fantastic, where you have nephrologists working with skin specialists, working with pain specialists. They're the experts in those areas, and they can really individualize the treatment. But some of the stuff they're doing in Boston is fantastic, and I think probably best if Dr. Nigwekar talks about those, particularly because they're pertinent to the US people.
Well, and I just know that when I saw those wounds on people that I know that had calciphylaxis and the pain, and then I just flash forward a little bit to 2021 in the U.S., you can't get a pain pill if your life depends on it hardly anymore. So it must be even more difficult because of all of our strict guidelines on pain pills, which there's a good reason for it. But I often find that it's harder now to get treated for pain than it used to be many years ago. So my hat's off to those of you out there suffering. So how serious is this condition? I mean, you heard, but explain, the outcome if it's not treated?
Yes, it is indeed a serious and potentially life-threatening condition. As Dr. Sinha was mentioning, a number of potential therapies or treatments get applied, but we do not have at present an approved therapy with proven safety and efficacy for this condition. So sadly, even after applying the currently available treatments, unfortunately, the outcomes are not optimal. Patients, of course, suffer intense morbidity as it relates to pain, the wounds, propensity for infections, frequent hospitalizations, so on and so forth. And I think what is really striking is the high death rates, especially for patients who are on dialysis and have developed calciphylaxis and have open wounds. The risk of infection is quite high. These individuals, of course, are ill to begin with because of their dialysis dependency and other heart or other systemic conditions. So on average, the 1 year death rate is around 50-60% in these patients.
Wow.
So that is quite a striking number. In fact, it's sad, but so this condition looks like, has even higher mortality than some of the most advanced cancers. And we hope that, as the cancer now is slowly undergoing the change in terms of having more effective personalized treatments, one of these days we will have accurate treatments for calciphylaxis. And I think that's what is making us quite excited with this new trial that we will discuss in the next few minutes.
Well, I have to say some of my favorite people are innovators and people who do research behind the scenes to improve our lives. So we're going to, talk a little bit about, through our discussion today, we've learned a lot about calciphylaxis and how it relies on symptoms management of the patient's wound healing and wound pain. I mean, we really have to do that. However, despite the care, the medical outcomes remain poor. And, sadly, patients experience severe pain and reduced quality of life. So there really is a need to find an alternative therapy for my peers, for people who have kidney disease, as there's currently no approved therapies other than, kind of the mismatch that you just talked about for the treatment of calciphylaxis. Do you have any information you can share with us about the therapies that might be in evaluation, which is really exciting?
Yeah, we're excited too, Laurie. So there is a study going on at the moment. It's a phase 3 clinical trial. It's called the Calciphylaxis trial. The purpose of this clinical trial is really to evaluate if this new investigational drug, it's got a jazzy name, SNF472, can actually improve wound healing and reduce that wound pain when you add it to the usual care or the current care that patients are getting for their calciphylaxis. And importantly, the safety of that study drug is also going to be evaluated in this trial.
Can you explain the clinical trial?
So a clinical trial is a medical research study. So it is a research study. And what we are aiming to do is we want to see if the investigational drug is safe and if it works. So there are health authorities such as the US Food and Drug Administration, you might have known of them as the FDA, or in Europe, we have the European Medicines Agency, so EMA. So they will oversee medical research studies. Participation in any clinical trial is always voluntary, and all aspects of this Calciphylaxis study have been approved by an ethics committee. So they're the ones that ensure that the rights of study participants are always protected.
And, explain, how does this drug work? I'm always fascinated with the science.
So this is, quite an exciting and novel product that is now, of course, in a phase 3 clinical trial for patients with calciphylaxis. So as we were discussing before, one of the main reasons that conditions like calciphylaxis develops is because of blockage in the blood vessels that supply different body parts. So, of course, with calciphylaxis, we most commonly discuss the skin tissue. And so there are these tiny blood vessels that supply the skin tissue. And if they are blocked because of things like calcium and phosphate, then the blood flow is limited. The skin doesn't get the blood supply that it needs. As a result, it may break down. There may be pain in the skin. So what this medication, SNF472, tries to do is actually it blocks the formation of those calcium and phosphate blockages. So that way the blood flow remains intact, smooth, and the skin continues to get perfusion from the blood. So it's really, I think, a very elegant mechanism to prevent those blockages in the blood vessels and restore the blood flow to the skin with, of course, the hope of improving the patient's pain and heal those wounds and then keep them alive by preventing infections.
Yeah, and I think it's probably worth also noting that, this study drug has been used in previous clinical trials. So, over 200 patients receiving hemodialysis have received SNF472. It's also been studied in a previous clinical trial in hemodialysis patients with calciphylaxis, and those participants had improvements in wound healing and wound-related pain after receiving the drug for 12 weeks. They've also looked at another clinical trial in hemodialysis patients, looking at, calcification of the coronary arteries. So we've heard today about calcification of the blood vessels that supply the skin. But in this study, they measured the calcification in coronary arteries. And that study showed that SNF472 reduced the further calcification even in those blood vessels. And in that study, patients received the study drug for 52 weeks during. And, it was generally well tolerated by the study patients throughout their time in the trial. And the effect was observed in patients who were also receiving their standard care. So it wasn't that like their other treatment was stopped and they just got this. So they also received their standard management for end-stage kidney disease, including their dialysis and prescribed medications for things like high blood pressure, lipids, phosphorus, and other things according to their primary treating nephrologist.
Well, who can enroll in this study? Do you have to have a diagnosis of calciphylaxis, or how does that work?
So the Calciphylaxis trial is currently enrolling adults, so it does mainly affect adults, so that's the population. But they have to be on hemodialysis, and they will have been on hemodialysis for at least 2 weeks. But obviously they have to have calciphylaxis, so they need to have at least one painful and ulcerated lesion. And it has to be diagnosed by a health professional, such as a nephrologist, but, or potentially a wound care specialist might be the person making the diagnosis. Eligible patients can, continue to receive other treatments. So a lot of patients receive intravenous sodium thiosulfate. They don't need to have a skin biopsy to diagnose calciphylaxis, so you can continue on your treatments and you don't need a biopsy. And study participants will continue to receive their regular care and their pain medications for their wounds, so we wouldn't deny that.
And how long is the study?
So the study in total goes on for approximately 6 months, of which the first 3 months is what we call a randomized blinded study. In that phase of the study, participants have 50% chance of getting assigned to the active study drug and a 50% chance that they may receive a placebo medication. And once that first phase of the study is over, meaning the first 3 months, then in the next 3 months, patients are receiving what we call like open label therapy with SNF472. So everybody who is in that second phase of the study will receive the active study medication, SNF472. So in total, it will go on for approximately 6 months, and patients who are participating will be very closely followed by the study staff during this period.
So can you explain why research studies are so important? I know this is kind of a given, but I think people need to really realize that that's how the future of medicine happens.
Yeah, absolutely. I mean, clinical research studies, they're so important because that's how we get information on what works and what doesn't. Ultimately, it's clinical research studies that give us the information that lead to new medications and treatments. And these studies will help us determine if these medications are, effective in producing the benefit that they're thought to, but also importantly, whether they cause side effects. So if people participating in clinical research studies contributes to progress in medical research, and we all want that.
If you agree to be in the study and you change your mind, can you, opt out at some point? And a follow-up question to that is, do you have to be at a certain location?
Yeah, so the study is going on in multiple countries and multiple centers across the world. So you, of course, need to be enrolled through one of those centers. So in that regard, you need to have an access to a center that is enrolling patients. But the trial is, going on pretty much all over the U.S. and many parts of Europe. So, very likely you will be able to find a center close to you that can enroll or at least evaluate and then subsequently enroll you into the trial. Like with any clinical trial, there is a description of the study to the participant before the participant decides to participate. And of course, they always have the right to not participate or discontinue the study if something comes up during the study period. But of course, this being designed as a clinical trial, what we typically try to achieve is even if a patient discontinues receiving the study medication, we still keep the patient in the study with the intent of gathering all the information that is being collected on that participant so that we have a very complete and a robust data on all the participants. But individuals can discontinue the study drug if something is going on with their trial. Absolutely, that is their right.
This is so exciting. And I just have a couple questions before we wrap up. What's involved if you're in the study? Just you get your blood drawn and then you get medicine during dialysis? Is that how it works, or do you take a pill?
Oh, good question. So it's a drug that's given during dialysis, so no tablets, and this will be in the patient information leaflet that people will get, and then they'll sign the consent form that goes along with that. But from a practical point of view, there will be a study schedule. I think that's the term that we use. So after the consent form has been signed, we're going to want to make sure that patient's pain is steady, that we're measuring that appropriately, and that we can actually look at the wound. So we'll be looking at the wound, taking measurements in different ways, and then making sure that we can track that. So we track wounds and we track pain. So for a period, we're just getting that steady, and then when the study trial starts, the trial starts properly, patients will either receive, kind of a dummy infusion, or they'll receive SNF472, and that's an infusion that's administered during dialysis. So, as a patient participating in the trial, you're probably not going to notice much because it's happening within the dialysis treatment itself. But there will be a lot of focus on your pain and what your wound looks like as parts of regular assessments, as well as some of those safety assessments that we mentioned earlier.
This is really exciting because like I said before, a couple of my friends have really suffered from this and there was no hope. And, I always say, just stay alive till the next miracle happens. That's what you need to do. And, thank you very much for sharing this information. Anybody who's interested, can get additional information at the trial by going to www.clinicaltrials.gov. And the number is, we'll have this on our website, but it's NCT 04195906. And that's depending if you can find the place on the website to put the number. Or you can send an email to info.cuatrial@sanifit, SANIFIT.com. And these contacts will appear on the page and somebody will get back to you if you want more information. I guess just to wrap up, and I had a thought, the name of this medication is SNF472. Maybe you could solicit the people who are in the study to name it. So down the line, we'll be able to pronounce it. Just a thought. But any closing remarks before we wrap up? And, I really appreciate all the great information.
I guess we just hope that people who are diagnosed with this condition will really want to participate in the Calciphylaxis trial. And, if you're a healthcare professional, then, refer your patients to the clinical trial site so that they have the opportunity to participate. So, really hope that people take this opportunity in a disease area that's so desperately needed.
People are suffering too. I mean, healthcare professionals have the opportunity to share something that could be life-saving. So do it, guys. Do it.
I would also add, the way that trial is designed, and coming to your point about asking the patients who are participating in the trial to name the drug, I think it's a brilliant suggestion. The trial has a lot of emphasis on the patient-reported and patient-oriented outcomes. The wounds and the pain intensity are some of the main outcomes of this trial. So really, this is a trial that should resonate with the participants and also the clinicians who take care of these patients. And we are, of course, as the investigators, are excited and really look forward to potentially helping these patients and completing this trial. And one of these days have an approved therapy for calciphylaxis, which, by the way, has been around for, over 6-7 decades at this point. So this is not a new entity, but unfortunately has been ignored for a variety of reasons, including its rare incidence.
Well, again, some of my favorite people are innovators and researchers. So I thank you so much for sharing your information, and I look forward to interviewing you guys again when you have the results and you're FDA approved and we've rid the world of calciphylaxis.
Thank you, Laurie.
Thank you.
Thanks for listening to Kidney Talk, a program of Renal Support Network. Please make sure to find us on Facebook or sign up for our newsletter at rsnhope.org. Kidney Talk is intended for informational purposes only. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment from your physician. Always seek the advice of your own healthcare provider regarding your medical condition.